Thanks everyone. Welcome for joining me. I'm Tom Ryan, and welcome to the webinar for Excluding Services from the Hospice Election. We'd like to help you avoid these types of claim denials when possible. Again, I'm your presenter. I'm Tom Ryan with Provider Outreach Education. Today I am joined by Ashley from my team. She's going to help with those chat. You can put any question you want into the chat at the end. Hopefully we'll have time to answer those. Want to remind you to look at the end of the presentation and to review the disclaimer. Want to also let you know we did have some questions about billing for hospice services. Now, billing the actual hospice claim, we are not the Medicare administrative contractor who processes hospice claims. If you have billing questions about the actual hospice claim or the election, you must contact the hospice MAC, which is the Medicare Administrative Contractor. It's the HH&H MAC, or Home Health and Hospice MAC, for your state. We, on the other hand, do handle other claims, and that's what we're here to talk about today. So let's get started. To provide guidance is our goal. What we're trying to do is to avoid these claims. Someone asked, do you provide guidance on billing Medicare Advantage plans? And the answer is, I'm going to answer that question as we go, because Medicare Advantage plans do not typically pay during a hospice election. Now we'll answer again where that comes from. I do want to give you some basic information because there's some pieces in there that are very important, and we did have some people actually indicate they're new to Medicare or that they're new to billing Medicare during a hospice election. And either way, I want to make sure you have the basics, okay? We'll then explain the data that I looked at, what's going on within the denials, what's happening within the claims processing systems to show that this education is needed. Last, we'll explain some claim requirements to exclude services from a hospital bill. Sorry, my mouse just scrolled forward there. To exclude services from a hospice bill. Now that's the hospice billing Medicare, you billing the hospice then paying you. This is when you can directly bill Medicare even though there's a hospice election on file. All right. So starting with just some really basic information, I do want to answer a few questions during this section. Okay? First of all, is hospice a Part A or B covered benefit? It is normally a Part A covered benefit. Now we say normally because there are components of it that can fall under Medicare Part B. Remember, Part A is inpatient and hospice. That's how it's defined by category. However, if they don't have Part A, then it falls to Part B, and Part B is outpatient, and it also has some different hospice benefits. So it's not truly either one. So with that said, is there a place that you can check to see if hospice is applicable for free? And the answer is yes. You can check the SecureNet Access portal available on our website or in direct data entry. You want to look for a HIPAA eligibility transaction, which is HETS, which is also available directly to you through a vendor. So there's some basic eligibility pieces that go with it. And I forgot to move the slide on that one, so I'll apologize. Just as an example, one of the big ones that we do encourage you to use is our website, which is the SecureNet Access portal. Before I go any further, I'd like to open the website up for you and just show you what I'm talking about. Here's the WPS website, wpsgha.com. If you notice on the right side of the screen, just below the navigation bars, there's an area that says login, and it gives a user ID and password. This is the SecureNet Access portal. It will remain there until you log in. What I want you to do is come to the bottom on the right corner of this and select the portal user manual. As you scroll through, now you can't directly see the hospice selection. Look away if you don't want to. I'm just scrolling down until I get to that section. But what you can do is look at the eligibility area under the patient information. And when you look at the eligibility check, you'll enter all the information. Again, look away if this is too much for you, and I'll tell you when to look back. As we scroll down, you're going to tell us all about the patient. You're going to enter the patient information. You're going to go to the eligibility area. Then we're going to give you some boxes. Now, these boxes will appear on your screen, and you'll start with a summary. If you go to the second line and move over 4 boxes, you'll see the word hospice. This means there's a hospice selection on file for that date of service, but it will also then tell you a bunch of information. So you can scroll down within this manual to read that information. Okay. But I want you to note that the hospice selection has to be on file first. It's not on file, it's not going to display within this section. Okay. So how does a hospice selection get to be on file? Let's keep going with our PowerPoint. And the first thing that happens is a certification must occur. Now, a certification is from a doctor that says the patient is terminally ill. If this terminal illness is left to run its normal course, that is under 6 months. That means they will not be receiving medical care, medical treatment, or any other form of that for write down for that condition. Because it doesn't mean they cannot get medical care. It's two different things. They can get medical care for a broken arm. We don't want them to suffer and not treat that broken arm, but they also don't need medical care for cancer or for renal dialysis. That's not what they're asking for. Okay, hospice allows them to run the normal course for whatever the condition is. So it doesn't exclude all medical care. All right, so that's basically what we're looking for. Now, the certification does occur within the patient's election. So while the attending physician does the certification, and that's more down here in the benefit policy manual, we don't want you to forget that the patient must first elect hospice, and then during that election, they designate a certifying provider, and that certification is then given to us. So we'll talk more about that. Someone said, what is the certifying provider? It is the attending physician, which we'll talk about again in just a few moments. The patient elect.
I'm getting some feedback, and I'm hearing it as well. Your audio is breaking up quite a bit.
There's nothing I can do with that. So I can move my headset. I don't know if that helps any.
Okay, we'll try that.
I'll let everybody know that the audio stays choppy and it's not a good quality recording. We won't be posting it. So just so everyone's aware of it. I'm doing the best I can. I don't know why it's breaking up, but I'm not sure what's happening. Sounds, as far as I can tell, it's clear. So I apologize for that. All right, so patient election. What we're talking about here. The patient election is the patient telling the hospice provider, you are going to be my hospice provider. Here's who I'm going to designate. They can designate the attending physician or who's going to treat them for that condition or who's going to manage that condition. They're not really treating them, they're really managing it. Now, if they do not do that, then it will automatically fall to a hospice director. This does have to indicate that they are accepting comfort care or some other form of that term. They are waiving medical services, Medicare covered medically necessary services for that condition. That's all part of the election. And they do have to tell us, hey, when does this start? So that's what the election is. Now, as I said, it has to designate an attending physician or will auto default to the medical director for the hospice. But what is or who can be an attending physician? Let's move on for that. The attending physician can be a doctor of medicine or osteopathy that is not employed or is not part of the hospice. So if you have a voluntary medical director, if you have a voluntary hospice director, they're still part of the hospice, though they're not getting paid for that service. Okay, they do not need a separate election. On the other hand, if the patient says, I want my regular physician, my primary care physician, whatever term they're using, to manage my hospice care, that's who they're designating. They could also use a nurse practitioner or a physician's assistant. Once they do that, though, they do need to tell us the full name, office address, NPI, and any other information identifying that attending physician. A lot of people say the term physician in this case is misleading because what if it's a nurse practitioner or a physician's assistant? I'm using the term physician in a general, overall, broad category, just like CMS does. We're not saying it has to be a physician. That's why we define for you that it could be, but it could also be a nurse practitioner or physician's assistant. And I want you to keep that in mind as we go through the presentation. All right, the election comes next. How long is an election period? Keep in mind, an election is good for 90 days, but automatically renews. So once the patient says, I want to do it, we just keep one election, it keeps going. That doesn't mean the certification automatically renews. It's 90 days, 90 days. There's two certifications. Then it moves to 60-day periods for certifications. It can be as many 60 days periods as the patient remains alive. But remember, it's a 6-month expectation. So 90-90 is the first two, and then it's 60 days. That does mean it goes back to the physician managing the patient's care to recertify that they still need the service. The election gives it who it is, and then it has to be recertified. Hopefully that makes sense. So what happens if a patient says, hey, I don't really want to be in this anymore. I'd rather move back to medical care for this condition. The patient must file a written revocation, and the hospice provider will file a claim. That claim then terminates the hospice care and allows for regular Medicare medically necessary services to be provided. Okay, so did you catch that it has to be filed? But it does need to contain the effective date of the election period, the revocation effective date, and it has to be revoked by the patient or their representative, which means they have to sign and date it. Otherwise, how do we know what the effective date is and when it was signed? Hopefully all of that does make sense. So why do we talk about this type of a denial and what happens with it? CMS has set in place the Hospice Prospective Payment System, or PPS. This system di- bundles all services for the hospice-related diagnosis into one payment. One payment. This payment is to the hospice provider, and they are then responsible for managing the care and paying any provider who performs a service related to the hospice. That is where it is coming together. It is a bundled service. Okay? Medicare assumes that your service is related to hospice unless you bill it otherwise. And we'll talk more about the modifiers and the condition code to do that in just a little while. Okay? The goal of this is to save the patient money. They have a hospice copayment. Instead of having a hospice copayment plus a Part B deductible plus a Part A deductible for this, it's too much. We want just for them to have the hospice money. This also is to allow the hospice to monitor all care given to their patient so they know if they're still receiving medically necessary care. That's what the goal is, but this then does create some different denials. Home Health and Hospice, MAC, processes all hospice claims. We do not do that. When a hospice claim is entered into the Home Health and MAC processing system, it creates unsolicited responses for anything that have been processed without certain indicators on it. That is the G W and GD modifiers. There's also a condition code. We'll talk more about that in just a few moments. This unsolicited response tells the Medicare administrative contractor for Part A and B to take money back because the hospice care overrides that and bundles the payment. Somebody did ask a very good question, and I like this question a lot. Does the hospice provider bill the services the same way as we would? Now, I'm going to assume that when you say we would, you are a Part B billing provider. I will tell you this particular person was billing on a 1500 or an 837P. That was one of the data selections. So let me explain. The answer is no. You can bill those services as they occur. It could be, 2 days after. It could actually be, if it's in the morning, the day of. It just depends on how fast you get to it. A hospice provider bills monthly for all services within that month. So think about that. Let's say it's the month of March. They don't bill that March 1st. They will not bill that until March 15th. But if the patient elected hospice on February 12th, they bill the hospice election on February 12th. Then they bill the February services, the March services, the April services. By the way, they all have to process in order. So the patient drops hospice on April 5th. No longer want hospice care. I'm disenrolling from hospice. That will be billed either right after they do it on April 6th or a little bit later, but it could also be held up if any of the other months have not processed. So hopefully all of that makes sense. They do not bill on the same cycle as you do. I want to make that about as clear. So home health and hospice MAC, HH&H, they process the hospice claim. Other MACs, such as the A and B MAC, like WPS, process all other claims for Medicare, with the exception of Medicare Advantage claims, and we'll talk more about that in just a little bit. So that's where we say, hey, what does the information show us? What does the claims processing system show us? What's the problem? What's going on? And how do we address that? And that's what we're here to talk about today. The data, how do we address it? Which modifiers do we use to help it? And should we really even be billing this? Or why am I getting those unsolicited responses saying, hey, it's not necessarily that you did anything wrong, it's two different processing systems, so now you need to fix it by submitting the modifier. Hopefully all of that makes sense. So I would like to take just a moment, and actually, do we have any questions before I move on to the data section?
No questions in the chat.
Did moving my microphone help at all for clarity for breakup?
Yeah, it seems to have helped.
Okay. So hopefully it's not so bad when I listen to it that we can actually still post this on, but I just wanted to bring that up. All right. The data. What we look at from data is, remember, we are a Part A and B Medicare administrative contractor. That means no, we don't look at whether or not the hospice claim came in. What we're looking at is to make sure that claims related to the hospice are billed and paid separately, or are billed and bundled correctly. And that's where our data comes from. Now we do have to look at two different processing systems. Part A line of business, which is billed on a UB04 or 837I and contains both Part A inpatient benefits and Part B facility outpatient services, are processed in a physical intermediary standard system, or FIS. Okay, the home health and hospice MAC also uses FIS, only they control the hospice portion with the hospice claims. FIS does have national and local edits, so the home health and hospice can write their own edits, so can our AB MAC, which in this case would be WPS. The other portion of that is for professional services, which are not related at all to the facility side, so a doctor's service, things like that. Non-physician practitioners such as the PA and the NP, which we mentioned, the nurse practitioner. Basically, though, when you look at this, and you will hear the term Part B, these are not all Part B. These are Part B benefit category services that are billed on a CMS 1500 or 837P. These are billed to the ABMAC, and we do process these alone. These do have, again, national and local edits, and our MCS only processes Part B services, unlike FIS, which processes both Part A and B because hospitals and facilities can still bill for outpatient services. So hopefully all of that makes sense as we get into the data. Why is this important? Because we're going to talk a little bit about how the data is affected by facilities billing, and also by outpatient services and professional services and lab billing and all of that. So we'll get a little bit more into that. I was specifically asked if I could provide you guys the filters or what data am I looking at. I think the question was more along the lines of what data, what did you look at? So first, I did not filter for national data. What I did is filter just for our jurisdictions, which is Iowa, Kansas, Missouri, Nebraska in one, jurisdiction 5, and Indiana, Michigan in another. Now that's jurisdiction 8. Jurisdiction 5 also contains an element on the UB04 or 837I of different facilities across the nation. So there's a little bit more data within that. What I did is the last quarter of 2025, and then I said, okay, what do we have going on with it? We looked by line instead of by claim. So we have 132,366 lines, which are $18 million, a little over $18 million in claims. I did then look at FIS versus MCS claims, and I will tell you, I was looking for return to provider, rejected and denied within FIS. Return to provider means we couldn't process it, there's something wrong, you got to submit a new claim or fix it in the system. Rejected means it's a technical denial. In this case, what's the technical denial? Why can't we pay that? Well, because it should have gone to a different contractor. We do not have medically necessary denials in FIS for this reason. MCS does break into two categories, and it breaks into we can't pay it or it's denied go to a different contractor. That's it. Yes, denied go to a different contractor versus making it unprocessable. And because the system edits work differently, that's why we assign the categories in that way. A little bit more about the FIS data. Again, remember this is the UB04 or 837I data. The return to provider was not adjudicated, so the submitter must fix it. You can see it with $73,000, and that is how many providers and patients and all of the claim units that were affected based on that. The second item was the rejected ones, though it's adjudicated, it's just not a covered service. Why isn't it covered? Because it should not have come to the Medicare A and B Medicare Administrative Contractor. It should have gone where? The Hospice Medicare Administrative Contractor. And then I broke it down for you in dollar amounts, providers, and all that different same information. I'm not going to read that to you. I think you're perfectly capable of looking at it, but I did want you to have it just in case you have questions, and hopefully that will then fulfill those people that were asking me questions. Same thing for MCS. Remember, this is our 1500 or 837P. We do not have anything unprocessable. Instead, we do deny them. Now, these are adjudicated as not covered services. This means they are not appealable. And this is a little over $18 million worth of services, but then we break down. So again, I want to point out service units at 131,000, almost 132,000. I'm going to jump back a slide. Here again, you have 500. So lots more in the Part B world than in the Part A world. And normally that's because the Part B world is where more of the services are being provided that need to be excluded, but also more in the way in which they bill. They bill faster than typically the hospice does, sometimes even before the election is filed. So you'll check it out, you'll be like, hey, I did everything perfectly, but I still got this weird take back. The weird take back comes from the unsolicited response because you billed your Part B service to the MCS system before the hospice billed their election. And once the election was billed, the system went flag, take the money back. So that's the data that we use, and I just wanted everyone to kind of be aware. Hopefully that answered the questions that we did have come in on the data. If not, I do need you to put some information in the chat and help me understand what else you're looking for. So when we look at excluding services from hospice payments, hospice bundling, this is something that you must tell us needs to be done. You must tell us needs to be done. So how do you do that? Let me talk about the modifiers and condition code next. First, GW modifier means that this service is unrelated to hospice. This should be the most used modifier. It's a service by service basis or a line item basis. So it can be built on a UB04, it can be built on an 837i, it can be built on a 1500 or an 837p. It really just depends. And it's billed by line. So if you got to make sure it's all the way across. The one exception for this is, hey, I've got an attending physician. I am going to say this is related to hospice, but I'm going to tell you that I'm the attending physician for that hospice care. Well, that's a different modifier. We'll talk about that next. So someone asked, for instance, they have an ambulance transport, and the scenario given was they have an ambulance transport from the hospice to the emergency room because the patient has a laceration that is continuing to bleed. Now, we don't really know in this scenario. They didn't tell me whether it was related to the hospice condition. Going to assume it's not because that's what they were asking me. That's when you would build a GW modifier. So let's say the hospice condition is cancer. They're getting some kind of blood thinner or something so they can't get the bleeding under control. That is a unrelated condition. But even though, or I should say, even though maybe the blood thinner or maybe whatever is going on that's making the bleeding uncontrollable is related, it really is still unrelated. In terms of Medicare's looking at whether or not you should append the GW. Okay. So GW is any condition unrelated to the hospice condition, okay, including overriding factors, accidents, illnesses, things like that that just aren't related to the hospice. GV is the other one that people are very confused on, and I just want to remind you that GV is used very infrequently, should never be used by a hospital or a facility billing for those charges, should never be used by a supplier, such as an ambulance supplier or a lab. It should only be used by, again, that term attending physician. So remember, it was a physician, nurse practitioner, etc. There's just those three, and they should only use the GV when they are listed on the hospice election and are performing their care, their oversight of the hospice. Yes, you're going to bill that service, but you must append the GV to say, yes, this is a hospice-related diagnosis. Yes, I understand there is a hospice election, but I'm listed on there individually, and this is a separate payment because of that. So hopefully all of that makes sense to everyone. GWGV. The last thing that we do have to make it unrelated to the hospice, is condition code 07. Now, I will tell you there is a typo on my slide. It says UB04 or 837P. That is not correct. It's UB04 or 837I. I is for institutional transaction. On there is a field for condition codes, and the condition code 07 can be appended to indicate everything on that claim is unrelated to hospice. This is not always the case because you are required to bill all services. On one claim, you may sometimes say, well, oh man, this one is and this one isn't. That's when you default to the modifier GW. So don't use condition code 07 unless the whole claim is. If the whole claim is not, then you got to go line by line, and on that line item, man, then you're going to append the GW. But again, that's only applicable for the UB04 and 837I billers billing to FIS. If you bill to CMS 1500 or 837P to MCS, there's no condition code. It's not even a field for it. It doesn't apply. In that case, you must use the modifier GW or GV. All right. Okay, let's move on. Just for a second here. One of the questions that comes up frequently And in today's questions, this was no exception. So I thought maybe what I should do is just build this in so you have the information right away. So first, I do want to remind everybody that Medicare Advantage plans are different than traditional fee-for-service Medicare. Medicare Advantage plans began under a different section of the Social Security Act. In that section, they do not have to pay for hospice care. CMS then gives them guidance on their particular set of information. Now, I want you to take a look down where it says Medicare Benefit Policy Manual, Chapter 9, Section 20.1. That's an incorrect benefit. Ashley will put the link down below. So it's the Medicare Managed Care Manual, Chapter 4. So we can use this link, we can open it up, and it's going to be the wrong information because Tom didn't look fully at this. What this information for you is does talk about the timing and content and all of that. But if you notice, it's actually the Medicare Benefit Policy Manual, Chapter 9, coverage of hospice under health insurance. So it's not completely the wrong information. There is also Chapter 4. Now, again, this is just the continuation, the timing, all of that. This gives you that basic information. If you're looking at why Medicare Advantage plans do not cover it, what you do have to do is come to the CMS website, go to Medicare, then you're going to use regulations and guidance, manuals, internet-only manuals, and then scroll down. The first 9 chapters will be listed, but I need you to move on to that. And I need you to move to the second page where you see Medicare Managed Care Manual, which is 100-16. Once you enter in 100-16, you scroll down a little bit. What are you looking for? Chapter 4. Okay, this is the benefits and beneficiary procedures. And then within this chapter, you want to look for 10.4, which is hospice coverage. And within that, you will find some information. Oh, it didn't go there, sorry. 10.4. So I'm just going to get down to the section so that you guys can see this. If you go through, if you notice there's a big paragraph right here, and it says an MA, Medicare Advantage or Part C enrollee elects hospice but chooses not to disenroll from the plan, is entitled to continue to receive their MA benefits. Okay, they are responsible for, but they are other than those hospice related. Catch that right here. Under such circumstances, the MA has paid a reduced capitation rate for the enrollee by CMS, and the MA plan is responsible for continuing coverage other than hospice care. CMS pays the hospice program for hospice furnished services. That's after the election, things related to, they pay the hospice program. And the MA plan providers and suppliers for other Medicare services furnished to the enrollee during the original Medicare fee-for-service. This means that if it is a service related to the hospice care, this is what happens. It goes on a little bit further down. If you read through the rest of this table, it gives them some different options for how they can do that. And that's where we come up with the fact that, hey, by the way, it's not all exactly the same formula. Some people have asked me about this particular reference, which is the Code of Federal Regulations 42 CFR. It does begin to explain how all of this works, a little bit more about the table down here. So that's where we kind of get, if you look at this, okay, hospice, Part A's and B's, here's the MA plan or original Medicare. This is determined by the MA plan and how they direct this, so they can actually say, no, we're not going to pay for anything during that time, and they can refer it to original Medicare. Here's what you have to do for the rules, and it explains all these different pieces of information. So that gave us a big old long answer to say the MA plan has the right to refer you back to traditional fee-for-service Medicare for both the hospice related and unrelated services. It's right here in black and white. So if they have that right, you need to contact them to determine whether or not they are doing that. I can't answer that question for you. So hopefully that gave you enough information. I know it was a lot of information in a very roundabout way. One thing that we have been asked about is what happens when I get these overpayments? Am I required to pay them back? And the answer is yes, you are, but we do offer an appeal. And so you could appeal it saying, I need to append modifier GW, or I need to append condition code 07. Now, if you say I need to appeal with 07, my question to you is, are you just going to enter the system and correct the claim? Also very possible. You do that through direct data entry. If, on the other hand, you do need to send us money back, I want to talk about that. This unsolicited response has to be closed. If it's not closed, we will automatically take the money back from you. On the other hand, you can elect to do that. The best way to elect to send us money is through our portal and to do the overpayment claim adjustment, or if you, which is a request, like they now have hospice, except guess what? The hospice election hasn't been filed. That would be an overpayment claim adjustment. If, on the other hand, you get the unsolicited response, which is just us sending you a letter asking for money back, you would do the refund options. This is the best way to do it. Let me show you real quick what that's talking about. Again, it's sorry, I'm going to scroll back to the top up here. Let's go back for a second. You can see I still have my election or my secure net access portal right here, which I have not logged into. You can go to the portal user manual to read about it, which is where I'm at on this page. So that's anywhere you want to be, and you just automatically go there. Scroll down a little bit. Lots of information on logging in, practice information, great, great, great. Here's where you can see a lot of different information. Again, patient eligibility right here. Let's not forget to keep going down and hitting transactions. Under claims, you have the overpayment claim adjustment. This is when you discover they're in hospice and didn't know and you want us to request the money back. On the other hand, if we've requested the money back, then you want to scroll down to refunds down here to give us the money back. Hopefully that all makes sense to everybody. It's just the different ways to do that. On the other hand, we do have a form and you are welcome to use that if this is not going to work for you. I like to access it through the tools right here on the top. Go to all tools, be like, where are we going? How about all forms? Because I said it's a form. And then make sure you're in the correct line of business. Okay. Part A, UBO4 billers, 837I billers. Part B, 1500, 837P. And then the Iowa, Kansas, Missouri, Nebraska, you select J5. Indiana, Michigan, you select J8. Those national providers that fall under Iowa, Kansas, Missouri, Nebraska, you will also select J5. All right, scroll down to the bottom and you're going to see a big old list of forms. I just scroll through until I see the overpayment. Now, in the forms, the notification and the refund form are actually one. Remember, I said they're separate in the system, but they're right here. They're one. I want you to read through the information. It's great. Great information that specifies a lot of things. Here on the top of the form are the big fields that are messed up. And what happens is people are selecting incorrect jurisdictions, incorrect Medicare type by defined CMS type of business or line of business, not by benefit category, or they're not telling us which state the service was performed in. So if we actually open the form, you'll see those three right at the top. Okay. Contract, remember, is J5, Iowa, Kansas, Missouri, Nebraska are those national providers, and J8, Indiana or Michigan, and you select one. Type, Part A or Part B, is not a benefit category. Part A providers, you bill on a UB04 or 837I. That means you bill for both Part A and B benefits. Part B, you only bill for Part B benefits on the CMS 1500 or 837P. State is literally what service state were they at? Where were they physically located in the state that the service is being billed for? Hopefully that makes sense. So we wanted to remind everyone about that because we did get a couple of questions on overpayments. I'm not sure if I answered the questions. I will tell you the people that mentioned that they were being mistaken and then they have to repay or we send them money after the fact. I think what's happening is you're maybe using the paper form and you're not selecting all those top fields correctly, which means yes, we're getting it in time, but we aren't processing it to the right jurisdiction and the right processing system. And when that happens, we then sometimes have to issue overpayments back. All right. So there's a lot of basic information I thought I'd give you guys um, before we moved on to questions. Now, I know we have about 15 minutes or so left of the webinar, and what I want to do in this case is start with pre-submitted questions. We're going to then move into the chat questions. So please put as much as you can in the chat right now. Get ready while I talk about the pre-submitted questions. Okay, so the first one, hospice modifiers for dates of service after the data revoked but the same month. Example, it revoked on January 2nd, but the date of service is January 21st. Once the hospice revocation or end is put into the hospice processing system, you will not need a modifier. The problem is we don't necessarily have that in the hospice system yet. So then it hits your claim and your claim revokes for that, or your claim denies for that, or your claim doesn't process for that. So you want to wait, check the SecureNet Access portal, and just make sure that termination date is there. If it is there, you won't need it. The next question was one I wasn't really sure what you were looking for. You called it carve out during hospice, and I'm not entirely sure what that is. So when you look at this, are you trying to say you're performing services that are and are not related to the hospice diagnosis? In which case, you may have some services with the condition code, or I'm sorry, with the modifier, and other services without, which means some will bundle and some will not. I'm not really sure where you're going with that. When to use 07 condition code, when to use the modifier, I explained this. 07 condition code, entire claim, everything on there, every line on there should be excluded from hospice. However, the modifier will do the same thing on a line by line basis. If you said never want to use condition code 07, I always want to use the modifier, that's great. Okay. Need to understand when to bill a Medicare versus a Medicare Advantage plan. Hopefully I gave you enough information on that. I went over it very thoroughly, and the information is on slide 22. The one piece of information I did forget with slide 22. Medicare Advantage will not be paid because they're paid a monthly capitated rate. So if they remove their hospice or do their hospice revocation on the 15th of the month, and that's what's filed to us, Medicare fee for service, we will continue to pay until the end of the month because that's when the revocation can start allowing the hospice to be paid again. So that's probably the one piece I did miss there. What does the GV modifier represent, and how to appropriately use the GW for ambulance claims? First, again, GV, only for an attending physician and should never be appended for an ambulance claim. You are not a physician to start with. You are not a professional that would be able to be is eligible to be the physician managing the hospice care. GW, well, it could be appended to anything not related to the hospice. So a transport where the patient fell, a transport where there's something going on with this patient, but it's not related, or it's an underlying or overlying condition. Okay, so it could be part of the hospice, but it's considered whatever it happens to be considered. Now, for an ambulance transport, someone asked us about weakness, and I'm going to tell you that that does not necessarily mean it's going to meet medical necessity. If it does, then you could bill the GW. That's very possible. But if that's the only thing that you're going with, I'm not sure it's going to meet medical necessity. I don't have a whole lot of information because I don't know what's documented with that. What's the process if a claim denies after using the hospice modifier? Well, you have to check a couple of things. First, please look at your remittance notice and see if it has an MA01 remarks code. This means that you can do an appeal. What we're looking for is just to show why it's different. Like, we're seeing it, we're thinking it's part of hospice, it's bundling as part of hospice. Why is it different? And the way to do that is through the appeal. Okay. On the other hand, if it is part of hospice, we're going to say, hey, go ahead and bill the hospice. We did talk a little bit about this. Once the hospice is revoked, if the patient's on traditional fee-for-service Medicare, you will bill the AB MAC. If it is a Medicare Advantage plan, bill the ABMAC until the end of the month in which the revocation occurred, and then begin billing appropriately after that, which would be the MA plan. Why are the modifiers important? Because the Medicare system assumes that the bundling occurs unless we're being told otherwise. So the assumption is you should be billing the hospice for the conditions versus just automatically having us pay it. That's why the modifiers are important. Same thing with the condition code. Now, again, the difference is this person only bills on a 1500 or 837P, so therefore they would only use the modifiers. All right. Next question. Does the hospice diagnosis have to be the primary diagnosis on a claim to make hospice responsible for payment? And the answer is no. Any condition as related to hospice, so whatever happened to that patient could be a different diagnosis code. However, it's still related to the hospice care. That's what we're going to look at. The diagnosis alone does not drive that. Next, if a Medicare Advantage plan patient elects hospice for a specific condition and receives unrelated hospice care during an election, is the MA plan responsible? Remember, let's step back. We already went through that. It's on slide 22. Each MA plan has the right to legally make that decision. So my answer is not sure. Contact the MA plan. Start there. If they say we're not responsible, bill traditional fee-for-service Medicare. Be sure to include the modifier on that or the condition code. What services are entirely excluded from hospice? First, services that are not part of the Medicare benefit package program at all. So that doesn't mean that a hospice can't supply certain things that other areas can, but there are still some services that are not related to that. Two, services that are medically necessary and unrelated to hospice care. They would not be part of the hospice program, they would be separately billable. Um, what's an excluded service? Not sure where to go with that one, and here's why. Excluded service means Medicare never covers it. Yes, there are things that are covered under hospice. Once they elect to stop receiving the medically necessary care, hospice can cover that. So we really do have to refer you back, if they're under a hospice election, to the hospice DME, or to the Home Health and Hospice Medicare Administrative Contractor for that answer. Best way to correct the missing modifier. This was on a UB 04 or 837I. Please do a corrected claim if possible and direct data entry. Check the tape to tape field. If it's a denied claim, you'll be able to do that. If it is an RTP claim, verify the tape to tape field and then add the modifier. What condition codes affect the hospice selection and clear a definition of GV and GW? Again, we've already done this. This was on slides 19 through 21, slides 19 through 21. The condition code is 07. GV is only used for the attending related to hospice, but not employed by or not being paid by the hospice. Also, it has no relationship to the hospice. GW, all other services. So hopefully that answers the question. How to bill for hospice if the patient was seen in an ambulatory surgery center. I don't know how you bill the hospice. That is not between you and Medicare. The agreement that you sign with Medicare is not the same as the agreement you assign with a hospice provider individually. So how you need to bill them is up to them. How to bill for services not authorized by the hospice. Medicare does not have an authorization process. If the hospice says that, it's not part of the Medicare rules. They are still responsible. It's also part of their benefit package. Not sure what the hospice is going with there. Is there a modifier we can use once hospice denied the claim? Again, first determine whether or not they should be held responsible. If they should be held responsible, please bill them. If they should not be held responsible, look at the GV or GW and tell me which one is appropriate for the service you are billing. That brings us to the end of the pre-submitted questions submitted as part of registration. I'd now like to go back to Ashley and see if we have any questions in the chat.
We have a few questions in the chat. The first one is, if a patient falls due to weakness, how does that play into the hospice diagnosis? Is the patient's terminal illness considered responsible for the weakness? And then they say this is also an ambulance billing related question.
Okay, so a couple of things with the ambulance billing. Can you tell me if the patient falls due to weakness, why do you medically need to transport them? Now, if you say they've got a gash, they've got something else, that's fine. If they could sit in a wheelchair, could they safely go by a wheelchair van? If they could go by a wheelchair van, even though they're weak, it's not medically necessary. That's not hospice or Medicare. All right, let's say that it is medically necessary. The ambulance transport and the weakness, can you tell me what's causing the weakness? That's the problem. It's not like a yes or no absolute assigned on weakness. What's causing the weakness? Is it the terminal condition? Is it part of a treatment related to this terminal condition? I mean, is it not at all related to that? Maybe they are having something else going on, such as the flu. So they have a terminal condition, but because they have a suppressed immune system, now they got the flu, which caused the weakness. Then that's related to the flu, which is a medical condition, not the terminal condition, even though the terminal condition made them weaker, their immune system weaker. It's really hard to answer that because I don't have the details needed. And you can kind of hear that when I'm explaining some of the different scenarios. So Ashley, I'm going to leave that question with that and then go on to the next one.
Okay. All right. The next question is, does the hospice diagnosis have to be the first diagnosis listed, on the CMS 1500 in order to make hospice responsible for payment?
No, it does not at all have to be the first diagnosis. It could be somewhere on the claim. And again, that could be weakness, could be the primary diagnosis because that's what you were treating today, just using the example before that. And then the hospice diagnosis is what causes the weakness. Therefore, it's a secondary diagnosis, but it would still be hospice responsible. So,
All right. The next one is, if money is taken back, can we bill the existing hospice provider?
you should. Because that's what we're saying is it's related to the hospice care. But before you automatically just bill them, please make sure that you look at it and determine whether or not it should actually be appended with a modifier or the condition code. Because what happens if the election came in, this really isn't related to the hospice condition, and you should just append that versus doing the overpayment. And then billing the provider, the hospice provider. So a little bit more work into that one. Start with determining, and then yes, you should bill them. If you do not have the right to bill them because it's not related, then you need to fix the claim for us. Next question.
All right. Last one we had is nursing home visits during hospice. Who is liable for the service?
Well, the nursing home may be where they live, or it could be a skilled care. Let's use an example for that. A patient falls and breaks their hip. It's not that we don't want them to get their hip fixed, right? But they have, for end-stage renal disease, and they're not receiving dialysis. They've elected just to let that go. We don't want them to sit uncomfortably. So I don't know exactly. You know, most cases I'm gonna say Medicare because usually they're in a nursing home for something not related. Now, if it is truly related, if it is truly related to hospice, if it is truly related to um, other things like that, then that would definitely be billed to the hospice. Keep in mind, it's just a deciding factor of whether it is. So let's say that it's a break or something like that, an injury to an arm, an injury to a hip, an injury to a leg. That may not be hospice related. That would be separately billable to Medicare, but make sure you put the condition code or the modifier. Let's say it's hospice care, right? Hospice care. That would be related to the hospice condition. And let's say that it's neither one, of the patient just lives in the nursing home. That's not billable to Medicare at all. So I really kind of stuck with that one. And you actually said that was the last question?
That was the last one.
All right, perfect. We're going to go ahead and go on and we'll finish up. So let's go back to our slides here. We are going to give you a link in the chat and it's for a survey. We're also going to go ahead and when we close out of this, offer you the opportunity to take a survey with a pop-up box. It looks like that upper one in the right corner. It says external site. And then we'll give you an opportunity in the email that we send you out as well for this event, which is just a follow-up email. Things to keep in mind, that survey is 4 to 5 questions long. It should be fairly quick, so please make sure that you are, taking it if you can. Just give us that feedback. CMS looks at the feedback, and so do we, so it's important that we get it. Also, if you are listening to this in an encore, and again, I do understand it may be a little broken up, so I have to listen to the encore itself. I want you to look at the online survey, which is the little picture with the finger pointing up. That's an online survey. Take it there as well. But again, we really would encourage you to take this survey. Be honest. Give us the best feedback you have. Thanks for attending. I want to remind everybody we're going to send you an email just a couple minutes from now. That email will contain a certificate. That certificate has contact hours. Those contact hours are turned into a governing body. That governing body gives you CEUs or not. We don't know who does and does not, with the exception of a few of them like AAPC. They will issue it to you, but you do have to check that you don't have an index number, things like that. If you need directions on how to submit that, you will have to contact the governing body. We will take questions for the next 7 days. The questions must come to us in an email format, and it's wps.gha.education@wpsic.com. In the subject line, incorporate something with hospice, hospice election webinar, hospice webinar, election webinar, modifier GVGW webinar. Not really sure what you want there, but just make sure I have hospice or something related to it so that I know what you're looking for. They'll get those to me. I'll either email you directly or I'll email the group. Want to thank everyone for listening today. I hope that you got something out of it. Ashley and I would like to thank you for your time, and we hope that you will grade us, give us some information back on that survey. With that said, you can now disconnect, and y'all have a great day.